Good evening, web shadowers. We would like to thank you all for attending our session tonight. As in honor towards Breast Cancer Awareness Month, tonight we have the pleasure of hosting Dr. Robertson, a surgical breast oncologist.
As always, please remember that the Google form will be posted in the comments and on our Instagram bio at the end. With that being said, Dr. Robertson, you may start whenever you're ready.
Hi guys, I'm Dr. Yara Robertson. I am a breast surgical oncologist and I am located currently in Atlanta, Georgia. And thank you all for having me this evening. So a little bit about me. Let me move this out. Let's see. My road to becoming a surgeon, this is me in 1998 when I graduated from college from the University of Tennessee at Chattanooga. I took 2 years off after college because I wanted to enjoy my life. I almost got disowned by my parents, so I don't recommend you doing that unless you have a good understanding with your parents. But I became a certified pharmacy tech and I was a product tech at a blood bank and I really enjoyed what I did. I felt it got me ready for medical school and I felt more mature by the time I applied. So I applied to several medical schools and I ultimately chose the East Tennessee State University College of Medicine, which is in Johnson City, Tennessee. I'm a Tennessee girl. And in my third year of medical school, I became very interested in surgery. It was my last rotation of the third year. And I had gone into medical school wanting to do infectious disease, internal medicine. But surgery just seemed to be my calling. So when I finished my surgery residency, my medical school, I applied to several residencies and where I ultimately matched was in University of Arkansas in Little Rock, Arkansas. I did my internship and residency there. Residency takes about 5 years. You do research 6 years. And I became interested in taking care of breast cancer patients while I was there and stayed on an extra year to do a fellowship. That is me in my white coat ceremony from medical school, which you get your white coat to signify you're on your road to becoming a physician. That was in the year 2000, which was 20 years ago. Some of you guys probably was just being born. So a little bit more about me. I have spent 9 years in Atlanta, Georgia as a private practice breast surgical oncologist. And actually, I am about to move back to Little Rock to join a cancer institute in November. So 13 years between these two photos have passed. So to become a surgeon, you need to go to medical school, of course. You have to pass your board exams, which is step 1 and step 2. When you do your surgery residency, which can be 5 to 6 years, you do step 3 during your residency, usually your first year of your residency. I stayed on to do a fellowship, which is 1 year, but some fellowships, depending upon what you go into, can be up to 3 years. You have to do a written board exam, an oral board exam for surgery, and after 1 year in practice, you might see some physicians, especially surgeons, have FACS behind their names. And so that is when I had my fellowship induction in 2013. So it's a long road, but it's not impossible. So why choose surgery? So if you like combining operative and medical management of patients, it might be for you. If you like making definitive management decisions for your patients, it might be for you. If you like doing operative procedures, it could be for you. And general surgeons are able to do both long and short-term care for their patients. So for me, I chose breast surgical oncology because it was truly a multidisciplinary practice. Meaning, it wasn't just the breast surgeon deciding what happened to the patient. Multiple people are involved in the care of a breast surgery patient. Also, each patient is different. It takes a methodical approach to how to treat that patient. I treat people from men to women to teenagers to adults, and it is more than just surgery. Also, there's always something new in breast surgery. We're like on the cutting edge of research. And the most important thing is I love taking care of breast cancer patients. So breast surgical oncologists do a variety of procedures, and this is just a few. Patients will come in with a normal breast exam and they want me to examine their breast. I review their mammograms. I can perform my own breast biopsies. We do lumpectomies, which is what we call breast conservation therapy, where we just remove the cancer and not the rest of the breast. We do mastectomies. I put in ports for chemotherapy. I do aspirations where I take fluid out of things. I counsel people about their being high risk for breast cancer, and I can do genetic testing. So the first thing I want to talk about is the difference between a screening mammogram and a diagnostic mammogram. So a screening mammogram is routinely done to just make sure you don't have cancer. So patients are coming in with no symptoms whatsoever, and they're getting the 4 views of their breast. However, if they have an issue or they feel something or they've been examined and they have something, we usually recommend a diagnostic mammogram, which is different. A diagnostic mammogram is actually looking for signs of breast cancer, or maybe there's something on the mammogram that the first mammogram that alerted the radiologist that they need to be brought back for a different mammogram, something that zeroes in on what's going on. So a diagnostic mammogram is done when maybe they've done this annual mammogram, the radiologist saw something and they're getting a call back. So in here, you see that this particular one is kind of squeezes down and there's a mass there. And then you see calcifications here, which can be the earliest sign of a breast cancer. So a diagnostic evaluation is really tailored to the physical complaint of the patient. And it's really good at evaluating things such as if a patient comes in with pain, or they feel a lump, or their nipples retracted, or maybe they having discharge or something leaking out of the nipple. You may or may not have heard of 3D mammography. The 3D mammograms are basically mammograms that have digital. Our mammograms are done digitally now, but the most common way we do them are 2D mammograms. 3D imaging actually takes the breast tissue and slices it into very thin slices, like millimeter slices. It helps uncover masses that can be hidden by overlapping breast tissue. So tomosynthesis or 3D mammography actually decreases callbacks and increases the number of invasive cancers that can be detected. So this is a 2D mammogram, and this is like the basic mammogram that we do, but you can add 3D technology, and because they're slicing that up really thinly, you can see that they picked up a different cancer. So this is how a 3D mammogram looks. It looks just like a regular mammogram machine. The breast actually, is in the plates here, but this arm sweeps across the patient. It arcs over the patient, taking multiple images. These millimeter slices then are transmitted to the radiologist's screen, and it takes longer to read, but it does decrease callbacks and it increases cancer detection rates. So whenever I'm looking at a mammogram, this is actually a standardized system that radiologists do. They put a number on the mammogram to tell me how suspicious I should be. So a 0 means maybe they saw something and they need to have additional views, meaning I need to bring them back to do another mammogram and ultrasound. I like to see a 1 or 2 because that means there's nothing going on that I should be concerned about. A 3, if I see that on a mammogram, means that there's something there. It's probably non-cancerous, but we need to do a 6-month follow-up. A 4 is what I usually see when patients come to me, meaning I might need to do a biopsy on them. 5 means it's an obvious cancer. And 6 means it's a cancer that's been biopsied, but maybe that person is going through chemotherapy and we want to see if that cancer has shrunken down. So I know that a lot of you all may not have heard about the screening controversies, but there's so many different organizations recommending so many different things. We used to say start at age 40, and every year you should get your mammogram until your life expectancy is less than 5 to 7 years. But what happened was this United States Preventative Task Force decided to update some guidelines and wanted people to start doing it at age 50 and to skip every other year. They said that they don't believe in 3D mammograms, and for some reason at some magical age of 75, it wasn't beneficial anymore. Most people who are in the breast world do not agree with this. So my problem with these guidelines, especially for African-American women, we don't fit the profile of who really gets breast cancer because we get it younger than our Caucasian colleagues. So if we put off mammograms until age 50, it could put our life in danger. I see lots of patients between the ages of 40 to 50. So the recommendation may be appropriate for the general population, but for African-American women, it may not be a good recommendation for us. We typically get breast cancer less than Caucasian women, but when we get it, it's more aggressive, it's found at a later stage, and it's usually harder to treat depending upon what type we get. So it's not a one size fit all, so I don't really agree with those recommendations. The American Congress of Obstetricians and Gynecologists, as well as the American College of Radiologists and the Society of Breast Imaging, still recommend us getting our mammograms at age 40. And I say, unless you have 1 foot in the grave, there's no reason to stop. My grandmother was 85 when she had her diagnosis of breast cancer. She's now 95. When her doctor told her she was too old to be treated, she just got a new doctor and she probably outlived him. So she's still alive. So getting mammograms if are very important. It actually shows that you can be a 35 to 40% decrease in breast cancer rates since the implementation of screening. So this is just what we still recommend, age 40 every year, and there's no age limit. We tailor it to the health status of the individual. Sometimes a picture is worth 1,000 words. So I'm showing you here that this is when a woman can feel something in her breasts. These are like beads of a necklace. But if they're getting the mammogram every 1 to 2 years, something that small can be picked up on a mammogram. So it's very important for early detection. I can't say enough about that. So I wanted to talk about the different types of biopsies. So a fine needle aspiration I perform, that's where you take fluid out of a cyst. A percutaneous biopsy can be done ultrasound guided, stereotactic, or MRI guided. What that means is I have a device that's taking pieces of tissue out, cores, and I'll show that in just a second. Stereotactic is usually done in the mammography suite with a mammogram, and we do stereo images of the breast. It's usually for something that we can't feel. It's only seen on mammogram, so we have to use the mammogram machine to actually do the procedure. MRI-guided biopsies, we are taking pieces of tissue, core tissue, but it is done using the MRI to identify the area. That is typically done by the radiologist. An open biopsy is where I take a patient to the operating room and I make an incision and I take out a piece of tissue or I remove the whole thing. But ideally, I get asked this question a lot by students. Why not just take the whole thing out? Well, imagine if that's a breast cancer. That's information that I need to get in an minute. I will do a case that shows you why I need that information before I do surgery. If I know it's a young person or somebody that has something with very non-cancerous features on imaging, I can take them to surgery to remove it. But if it's someone that has a very suspicious mass, I need to take pieces of tissue so I can have the pathologist give me additional information. So the gold standard in any practice should be your open biopsy should be only 5 to 10%. So for fine needle aspiration, I use the ultrasound on the patient. And then I make sure they're very numb. I use numbing medication. And under visualization, I actually insert the needle and I draw out fluid. Now this is a cyst. This is a cyst. And the reason why I know it's a cyst is because it's hypoechoic, which means there's fluid in it and it's dark. This is not suspicious looking to me because it's nice and round. There is light behind it. It's not shadowing. And just for a little bit of anatomy, the skin is up here. This is breast tissue, and this is the muscle. And down here is the lung. So here, there's a needle going in, aspirating the fluid. We're taking the fluid out, and you can see it shrinking down. I send that fluid off to be tested in certain cases. If it's straw-colored, yellow, or green, I'm not worried about it. That's normal changes to the breast tissue. But if it's bloody, or if it's red or dark, I will send that off to be tested because it's not normal to find blood in a cyst. It might be some blood from me doing the procedure, but I always send it off to be tested just to make sure there are no abnormal cells in there. But cysts of themselves do not have a risk for breast cancer. An ultrasound guided technique is where I numb the patient up very well. I use the ultrasound and I use a device like this, which is a core biopsy. So as you can tell, this is not fluid, this is actual tissue. So it's taking out strings of tissue. That gives me a better idea as to what's going on, and the pathologist like core biopsies better. So this is just one type of device. This is a handheld device that's spring loaded that I use. I can also do stereotactic. This is actually the room that I use in our machine. It's vacuum assisted, meaning I'm actually taking pieces of tissue out, it's cutting the tissue out after they're numbed up, of course. But the device actually has suction to help bring this tissue out of the breast. So what's going on is this young lady is laying down. She has a cutout for her breast, and we're doing mammograms as she's laying down to identify the area that's abnormal. And typically that's done for things that we don't feel, like calcifications. And calcifications are just like what I said, calcifications, little white specks that sometimes you only see on mammogram. So for an open biopsy, I'm going to show you, this is what we call a fibroadenoma, which is a non-cancerous tumor that I find in a lot of teenagers and young adults. And the reason why I know this is not cancer is because it's nice and smooth. Now this this particular fibroadenoma is actually from a patient that I operated on, but this is not her ultrasound. I just got a representative ultrasound of a fibroadenoma. But there's no shadowing behind it. It's nice and round. It's homogeneous, meaning it's pretty, it looks the same inside. It doesn't look suspicious to me. So in some young people and some young adults, if I know that it's going to be benign and it's bothersome, this lump is almost six centimeters. So you can imagine if you have a small breast, this is bothering the patient, I'll remove it. So an excisional biopsy is I put the patient to sleep, we make an incision on the breast, and we take the whole lump out. An incisional biopsy is where I make an incision on the patient, and I rarely do that. I can usually biopsy things really well with an ultrasound, so I really don't like doing incisionals where I'm going in just taking a piece of tissue. If you don't have to put the patient to sleep for a biopsy, you try to avoid it as much as possible. So this is an ultrasound machine, which I know you all know, but kind of the way it works for anything you use it on, there are crystals that are inside the transducer, and those crystals are vibrating based upon the electricity or electrical current in the ultrasound machine. It bounces off and causes sound waves on the whatever we're looking at, and it is converted back to electricity or electrical activity, and it creates a picture on the ultrasound machine. So these three things I'm using because this is the cyst. I wanted to show you the difference. This is a fibroadenoma, which is the non-cancerous tumor. Look how nice and smooth that looks. But this is an ugly actor. Look at how it looks. It's very irregular. It's dark. It's got these calcifications in it. This is ugly, ugly, ugly. So this is actually a breast cancer. So if you see this, there's no reason to take somebody to surgery to remove it, to figure out what it is. That's an easy thing to biopsy. So we would numb the patient up with some lidocaine, make a small incision, put the device in, and take pieces of tissue out. So the two cases that I'm going to present tonight are unusual cases, but I can do a lot of teaching in between. So case one is a gentleman who presented with a left breast mass near his nipple, and has been present for 5 years and keeps growing. He only became alarmed when he started noticing blood coming out of the nipple. So what's some important information we need to collect? So yes, I'm sure I heard it. For your past medical history, I want to know what's his issues. He has high blood pressure. He's on a blood pressure medication. He doesn't have allergies. He drinks alcohol, and he has a mother and aunt who had breast cancer. Now, the reason why this is important to me is because I want to know, does he drink? Because alcohol can sometimes cause gynecomastia. And gynecomastia is breast tissue development in a male. Also, his family history is important because if he has a significant family history of breast cancer, I might want to make sure he doesn't have some alteration in his DNA that's causing breast cancer. And then certain medicines can also cause the development of breast in a male. Our review of systems is where we ask the patient different questions. And I really want to focus in as a breast surgeon to make sure we don't have any metastatic disease or disease that's gone somewhere else. Breast cancer, once it gets out of the breast into the lymph nodes, it can travel anywhere in the body. So it can go to the spine, the brain, it can go to the liver, the lungs, and it's not uncommon when breast cancer has gone to the lungs to cause a malignant effusion. And that means there's fluid in the lungs caused by the cancer. And when we draw that fluid out, we find the cancer cells. So this patient didn't have any symptoms other than the lump in the breast. So on physical exam, and honestly, the physical exam is not important for what I'm trying to teach you, but I just want to reiterate, no matter what a patient comes in for, you really should do an exam. You can get a lot of information from doing a physical exam. So you just don't focus in on the issue. So what I'm focusing on is that this gentleman has a development of breast tissue, and at the 2 o'clock position, he has a lump I can feel. I also, when I examine him, I examine his lymph nodes to make sure I don't feel any enlargement, because the first place breast cancer can go to once it leaves the breast is to the lymph nodes. So this is an anatomy, of course, a female breast, not a male breast, but we have the same anatomy, just not as much breast tissue. So we have the milk ducts, we have the lobules, we have the fatty tissue, the breast sits on top of the muscle and on top of the rib cage. So as you can tell, the lymph nodes drain the breast of fluid. I always call them like the drainage ditch. They just filter things. So if cancer, the first place cancer would go to once it leaves the breast is to the lymph nodes. And the lymph nodes can be everywhere in the body, but when I examine, I'm examining under the arms, beneath the clavicle and above the clavicle, and of course the neck, the cervical region. So what's next, web shadowers? Yeah, I heard you. So it's imaging time. And I already told you if a person comes in with a lump in the breast, we do diagnostic imaging, which includes a mammogram and an ultrasound. So this is what we felt on the patient, but he also had another lump in the breast. And all of this is probably involved tissue as well. So the man doesn't have very much breast tissue, but we ended up biopsying. Well, I'm not supposed to tell you I ended up biopsying, I'm supposed to ask you a question. But we ended up finding 2 masses in the breast. And what's next, I already cheated and told you. But yes, we did a biopsy. And I know you're not going to understand what this is, and I'm going to go through it really quickly. But we had an invasive ductal carcinoma, which is a breast cancer, grade 1. Grade 1 means the cells still look like it's normal breast tissue. And estrogen was there, progesterone was there, and HER2 was negative. And I'm going to go through that in just a second. So the most common type of breast cancer that we see is an invasive ductal carcinoma. This is what this gentleman has. The second most common type is DCIS or ductal carcinoma in situ. I can't make those sound any simpler because that's what they named it. But basically what happens is these cells start to grow and they become abnormal. So stage 0 breast cancer is DCIS, is where it's confined to the milk duct. Stage 0 breast cancer has a 99% cure rate, depending upon what we do for surgery, because it doesn't go anywhere. It stays inside the milk duct, but we still have to treat it because we don't know when it will turn into an invasive cancer. In each person, it's different. So invasive cancer is where these cells have actually gotten out of the milk duct into the breast tissue. And of course, once it gets to the breast tissue, it's a possibility that it can get into the lymph nodes and go other places in the body. I marked this one out because this is not a cancer. This is a high-risk marker, meaning if I see this in a patient's pathology report and nothing else, it just means that they're at increased risk for a breast cancer. So that should not be on here, but I still like this graph, so that's why I'm using it. So when I look at a breast cancer specimen pathology report, meaning I've taken the piece of tissue, I've given it to the pathologist has given a full report, I want to know what things make this cancer grow. So I look up tumor markers, and tumor markers mean estrogen, which is a hormone we all have in our body. Progesterone is the lesser known hormone. And I can't make this one sound any simpler. It's called HER2. I'm sorry, that's what it's named, but it's a growth factor. So for a minute, let's ignore the green thing and let's look at these two. The way to think about this is a cancer cell, and think of the cancer cell as a car. These are car seats, are what we call receptors. And the estrogen, which is a hormone, and progesterone are the drivers of the car. So in certain breast cancers, the majority of breast cancers that I treat, estrogen comes along, sits into the car seat and drives the car or drives the tumor. Progesterone comes along, sits into the car seat and drives the car or drives the tumor. For HER2 is found on most breast cancer cells, but if you have too much of it over an expression, it's a more aggressive cancer. So the reason why this is important in looking at these two is because there's a medicine we can give sometimes after surgery that keeps the patient from having to do chemotherapy. Now, there's a lot that goes into when a patient does chemotherapy, and I don't want to get into that tonight because it's kind of complex. But the pill that they take is an anti-hormone, meaning the pill actually sits here and pushes hormones away so that it doesn't make the cancer grow. Now, this breast cancer cell doesn't have any seats on it. So it's a more aggressive cancer because these people can't take a pill for hormone blocking because there's nothing for the hormones to sit on. This is a triple negative breast cancer, which is not uncommon, unfortunately, in African Americans, which is a more aggressive cancer. In these patients, if they have a tumor that's even greater than 5 millimeters, we have to do chemotherapy on them because we don't have the benefit of doing a hormone blocker. Now, don't freak out. You don't have to know any of this. I'm just showing you that breast cancer is complex and no patient is the same. We get all type of different pathology reports, but it's important for whoever's treating this patient to understand them. Triple negative was the one I just talked about, which didn't have any seats on it or receptors. That's a more aggressive cancer to treat. Triple positive, we have the HER2, that little growth factor I was talking about. It's an aggressive cancer and it has to be treated a certain way with a certain type of chemotherapy agent to target this growth factor here. The one that I love, and most well, we don't love breast cancer, but the one that we like to see is this one, because those hormone receptors are there. And I know that once I do my surgery, there is a possibility, depending upon other workup, if this patient may not need to have chemotherapy, and they can take a pill instead for 5 years, which is a hormone blocker. So these are the clinical subsets of breast cancer. The majority of breast cancers actually have those little seats on them, the hormones, for the hormones to sit. And then the other two, 15% are triple negative, and 15 to 20% are the aggressive triple positive cancer. So just an aside, breast cancers are found in men. There's 1 in 883 risk of having breast cancer, and about 2,600 cases each year in 2,600 cases in 2020 are expected to be diagnosed. So what are the risk factors for a male breast cancer? Having a first-degree relative, which is a mother, sister, or child. Having a genetic mutation, and I'll go over that in just a second. Having a disease such as Klinefelter's, which is elevated estrogen, and it causes breast development in gentlemen. Having had chest irradiation, excessive alcohol, some therapies for prostate cancer, and obesity all increase your risk for breast cancer. So what is a genetic mutation? The best way I can describe it is you have normal genes that work to protect against breast cancer. And when we get defects or alterations in these genes, it diminishes the body's natural ability to fight. So a way to think about it is you have a cell just doing its work on the assembly line. And then it has a boss that comes along and blows a whistle, holds up a stop sign, stop working. So the cell stops, it stops growing. However, in some people, we have what we call rogue cells. So that means there's maybe something happens where the supervisor who's blowing the whistle maybe gets hit in the head with a baseball bat. He falls over, so he's not doing his job. So some tumor suppressor genes are not stopping those cells from growing. Another side is I have a genetic mutation that causes kidney cancer. And so for me, the gene that's supposed to be stopping my cells from making tumors doesn't work. There's some kind of defect in them. So there are some patients that come in with breast cancer that actually have an alteration in their DNA. I've heard of the actress Angelina Jolie. She had a genetic mutation. She didn't have breast cancer, but her genetic mutation put her at increased risk for breast and ovarian cancer. So she removed her breast, and she ended up doing her oophorectomy, or removing her ovaries. The majority of patients that come in, though, do not have a genetic mutation. They simply get breast cancer for females because they're older and they're female. But 10% of patients come in with genetic mutations. And so we take blood or saliva for certain reasons, and I'll get into that in a second. And these are all the different possibilities of genetic mutation. The most common one are BRCA1, which is breast cancer 1, and BRCA2, breast cancer 2. These can put you at risk for prostate cancer, breast cancer, as well as ovarian cancer. And patients who have these have a 5 times greater risk for developing breast cancer, as well as 10 to 30 times greater risk in developing ovarian cancer. So for men, we check every male who comes in with breast cancer for a genetic mutation. So 1 to 2% of men with the BRCA1 mutation will develop breast cancer by age 70. And approximately 6% of men will develop breast cancer if they have the BRCA2 mutation by age 70. And it's not really common to see a man with breast cancer before the age of 50 if they don't have a mutation. I put Matthew Knowles up here, the father of Beyonce Knowles, because last year he was diagnosed with breast cancer and he does have a BRCA mutation. That means there's a 50% chance he could have passed this alteration in DNA on to either his daughter Solange or his daughter Beyonce. So Beyonce is at high risk for developing breast cancer, and I'm hoping that she is being followed closely. So I'm not going to go through all who should be genetically tested because you can find this on any website. But I wanted to highlight that a male needs to be tested if they come in with breast cancer, doesn't matter their age. If you have a known history of a genetic mutation, Ashkenazi Jewish heritage, they have an increased risk for having gene mutations, the BRCA1 and 2 gene. Having breast cancer, any young person less than 45, honestly, I try to get people tested under the age of 50 because it's not common to have breast cancer before the age of 50, but it does happen. And the triple negative breast cancer, the more aggressive breast cancer I was telling you all about, anybody who has it who is less than 60 years old, we tried to get genetically tested. Now they're saying everybody should be genetically tested if you have breast cancer, but the problem with that, insurance companies are not really allowing us to do that. So how do we treat breast cancer? We treat it almost the same way as we do for women. They have surgery. We do a lumpectomy where we just remove the tumor, but most often in men, because they don't have a lot of breast tissue, we end up doing a mastectomy. Some require radiation after we do surgery. Some need chemotherapy after we do surgery. And yes, we do hormone blockers on men too. This is not my patient, but I like this picture because it kind of signifies that a male gets breast cancer and can have the same side effects of having breast cancer as a female. So he's had a mastectomy. Apparently we've taken out some lymph nodes because he has lymphedema, which is where fluid builds up in the arm from doing lymph node surgery. So if you see, he has a sleeve on, which is a compression sleeve, which is pushing that fluid out of his arm. And he's apparently had radiation because he is standing in the radiation room. There's the accelerator behind him there. So this is a mastectomy in a male, and we do it almost the same way as a female. We make an incision around the nipple areola complex. This is a simple mastectomy. And we're removing the breast tissue. The nipple is actually attached to the breast here. And this is the pectoralis muscle. So the outcome of that patient is he had a mastectomy. We checked his lymph nodes and he didn't have any cancer in them. He did not require any additional chemotherapy or radiation. And he was offered by his oncologist the hormone blocker, but he declined to take it. And of course, his genetic testing was negative. And I'll talk about the implications of a positive test in a minute. Web shadowers, I don't see questions, so I guess I'll just do it at the end because I don't see the questions yet. So the next case is a 42-year-old female who presented with left breast pain. She denied any significant medical problems, and at 11 o'clock in her breast is where she was having tenderness. And when you examined her, when she examined herself, she didn't feel anything there. So what do we need to know about her? When did she start her cycle? Was she on any medications? Any allergies? Did she smoke or did she drink? And no family history of breast cancer. So of course, on anybody that comes in with any ailment, we do a physical exam, of course. But in her, I focused in, after doing the physical exam, on her breast exam. And when you examined her, she was tender at 11 o'clock in the breast. And I'll show you the clock face so you can understand exactly where it is. But she didn't have any nipple discharge. She had dense tissue, which is normal for a young person, lumpy breast tissue. And then we checked her lymph nodes, and her lymph nodes didn't feel suspicious at all. So this is breast here, and this is where the lump was felt. And the reason why I did the ultrasound first is because it was a little bit more interesting before I get to the breast cancer. But when you see this doesn't look super suspicious. I showed you an ultrasound earlier. And if you look at this is nice and round. There's a little bit of an etching right there. But of course, they wanted us to biopsy it to make sure it was benign. We did biopsy it, and it came back a fibroadenoma. So nothing suspicious. But in addition, remember, if somebody comes in with a lump in the breast, we want to do a diagnostic mammogram. So that actually was done first. I kind of cheated. I put this one first. When we did the diagnostic mammogram, they zeroed in, and we have these areas of calcifications, which calcifications cannot be felt. And I still don't think that her breast pain had anything to do with her lump in the breast. Very seldom do people come in with breast pain with breast cancer. But if you have a patient who has persistent pain in the breast, you need to evaluate. So for her, these calcifications required us to do a biopsy. It's the biopsy that I showed you earlier where the patient was laying on the table and the cutout for her breast. So that's how we biopsied this. And it did come back a breast cancer. It was a stage 0 breast cancer. This is actually her mammogram after the biopsies. So I kind of cheated a little bit. I don't have the mammogram that showed the calcifications other than this picture here. So for her, she had stage 0 breast cancer, which is DCIS. Remember I told you earlier, it does not invade the breast tissue. It stays within the milk duct. And it doesn't usually go to the lymph nodes, but we still treat it because we don't know in which patients it will go on to be an invasive cancer. DCIS, once we get a diagnosis of it, it's typically estrogen and progesterone positive. So remember I told you the hormone blockers you can use. So we do surgery and we can put them on a hormone blocker. Now for this patient, well, let me talk about this right quick. So this is a normal duct, a normal milk duct. And the cells can get a little bit larger, which is not abnormal. We get this in a biopsy all the time. Ductal hyperplasia does not concern me. But when the cells continue to grow, they can start getting abnormal and can start making, the DNA can start getting alterated and start making cancer cells. So typically, if they come in with atypical hyperplasia, this is something that alerts me that they're at risk for developing breast cancer. Not necessarily that they're going to get it, but they're high risk for that. So if I can see this, if they come in with this, I will take them to surgery, remove this area, not so much because we're trying to remove this, we're trying to look at the specimen to make sure there's no cancer there. And then we can do a hormone blocker for these patients so they don't progress on to an invasive cancer. So this patient had DCIS, or stage 0 breast cancer. As you can see, the cells are neatly contained in the milk duct. And invasive cancer is, if these continue to grow, we don't know in which patients though, but if they continue to grow, they can grow out of the milk duct and invade the tissue, which of course is the most common breast cancer we treat, invasive ductal carcinoma in situ. So for this patient, we got an MRI, and MRIs are not ordered on every patient with breast cancer. There are certain reasons why we ordered it. For this patient, we ordered it because number one, she was young, she had very dense tissue, so it was hard to examine her breast. And we just wanted to get the extent of disease on her. And also, I'll show you in a minute why else we ordered it, but I kind of went out of order. But if you notice, this is her left breast, and look at all of that stuff. All of that is stage 0 breast cancer. Her breasts are not very big, so there's really no way for me to take all this out and leave her a breast. So of course she would need a mastectomy to remove the breast because this is just way too much tissue. This is her other breast and it's completely clear. I will get back to your questions at the end of this because I want to get through this really quickly. Let's see. Okay, give me about 10-15 more minutes and I'll get you your questions, I promise. So who is at higher risk for breast cancer with young patients? 11% of all new breast cancers in the United States are found in women who are younger than 45 years old, and these are the risks. So if they have a close relative who had breast cancer young, if they have certain genetic mutations like we talked about, if they're of Ashkenazi Jewish heritage, if they've had childhood irradiation to their chest wall for things like Hodgkin's lymphoma, or if they have any of those high risk things I was talking about that are not cancerous, but they put you at risk for breast cancer. So remember, this lady is less than 45 years old. So since she's less than 45, I told you all, people who are less than 45 need to get genetic testing. So one of the indications is breast cancer less than 45. So we did genetically test her. We took blood from her. And guess what? She had a mutation. So she had the BRCA1 mutation, which remember puts you at risk for breast and ovarian cancer. So because she was 42 and had one child, she did not want to have any more children. And so just because you have a genetic mutation, if you don't have cancer, does not mean you need to rush to remove your breast. There are some patients that don't want to remove their breast with a genetic mutation. So those patients are followed very closely. We alternate doing mammograms every 6 months, a mammogram, then an MRI, a high-risk MRI. They come in and they get examined. I bring up every time they come in, hey, do you want to remove your breast? They may or may not want to, but they have to know their lifetime risk. So it's not a small amount. So this patient, her lifetime risk by the time she was 80 is a 60% chance of developing breast cancer. So for her, she chose to remove not only the left breast, which was of course full of cancer, we needed to remove it, but also her right breast because of her risk for developing breast cancer. In addition, she had her ovaries and her uterus removed. Now, ovarian cancer is very hard to detect. There's really not a good screening tool for it. And when we do pap smears aren't looking at ovaries. So a person who comes in with a genetic mutation that increases the risk of ovarian cancer, we will send them for a particular type of ultrasound to look at the ovaries themselves to make sure they don't look abnormal. And then we get a specific type of blood test on them called a CA-125 to make sure it's not elevated. If you just remove your ovaries, you decrease your breast cancer risk by 50%. And there are some patients that don't want to have their breasts removed, but they would rather have their ovaries removed. Every patient's different. So having a genetic mutation does not mean you need to rush to remove your breast, but because she has breast cancer, she made the decision to remove the breast prophylactically on the right side. So I put these on here because these are the different ways or the different types of mastectomies. And a radical mastectomy is rarely done anymore. That's where we're removing not only the nipple, the breast tissue, the skin, we're removing some of the muscle. Now, I have done this from time to time in patients who come in with very advanced cancers that are invading the muscle. But the majority of time, we can give them chemotherapy before we do the surgery, and we can get it to shrink down some so we don't have to do such a radical procedure. This is a very disfiguring procedure. We rarely do this anymore. A simple mastectomy is where you're removing the nipple, the skin, the breast tissue. We may or may not remove lymph nodes, and I'll show you in a minute why I say that. And we close the skin back up. This is the skin sparing mastectomy, and this is not my patient. This is a picture I got off the internet because I would never put an incision like that on a patient because I like to hide things. But a skin sparing mastectomy is where we take the nipple, we take the breast tissue, we leave the skin behind. We make sure that the cancer is nowhere near the edges of the skin. And then the plastic surgeon puts an implant in and they close them up. They get a nipple reconstruction down the line. But this particular patient that I was describing actually had a nipple sparing mastectomy. So what we did was her incision is underneath her breast on both sides. We took all the breast tissue out. We checked her lymph node. We left the skin of the nipple behind, and the plastic surgeon came in and put a implant in. And these are just the different ways that we do surgery. A partial mastectomy, also called a quadrantectomy, also called a lumpectomy, is simply meaning we go in and remove the cancer and remove a thin layer of tissue around it to make sure we don't leave cancer behind. That's breast conservation where we don't remove the whole breast. Certain patients are able to have this particular procedure. A simple mastectomy was this right here, where for invasive cancers or cancers that have gotten out of the milk duct, we will do a sentinel node biopsy, and I'll show you in a minute what that means. So a modified radical mastectomy is usually somebody who we know they have cancer in their lymph nodes, and we have to remove the breast, the skin, the nipple, and the lymph nodes as well. And of course, the radical mastectomy, I told you, we rarely ever do, but for very advanced cancers. And unfortunately, in Georgia, I have seen advanced cancers that have required us to remove some of the muscle because they have been neglected for so long. So her final pathology was ductal carcinoma in situ, which is stage 0 cancer. And remember, I told you she had a total abdominal hysterectomy because of her risk of with the genetic mutation of having ovarian cancer, but we didn't find any cancer within her ovaries or her uterus. So for the lymph nodes, I want to talk about this really quickly. So for cancers that get out of the breast tissue, not everybody's cancer has lymph nodes that have cancer in them, but we do a sentinel lymph node. A sentinel means first. So back in the day, way back before I became a breast surgeon, we used to take everybody's lymph nodes out. You remove the breast, you took all their lymph nodes out. And the lymph nodes, some of them drain the arm. So if you remove them, their arm can get really fat and swollen. So in the 1990s, they came out with a different technique. So this different technique is the patient either goes to radiology to get some radioactivity injected into the breast before surgery, or at the time of surgery, I can inject blue dye right at the nipple or at the tumor, and it's taken up by the lymph nodes. So it mimics where cancer would possibly go. So I'm not saying the person has breast cancer that's gotten into the lymph nodes, but this mimics it. So I'm not having to take every lymph node. So the blue dye or radioactivity travels down the little lymphatic channel, gets into the lymph node. And so the blue lymph nodes that are blue, the lymph nodes that are blue are the lymph nodes that have the radioactivity, because I use a little device to listen. We put it on the lymph node and it makes a loud sound. We take those out and we send them off to be tested. The pathologist will call us back while we're in the operating room and will tell us if there's cancer in the lymph node. And if there's cancer in that lymph node, when we're doing a mastectomy, we will remove some more lymph nodes. It's called an axillary node dissection. But this has been a technique that has changed, having to remove every lymph node in a patient. Before we end, I want to talk about triple negative breast cancer because it's so important. This is the breast cancer that is more aggressive. It doesn't express any of those tumors markers that I was telling you about, the estrogen and progesterone, those little receptors that sit on the tumor that it doesn't have, if you remember when we started way back a couple of many slides ago. So 15 to 20% of those women have been diagnosed with triple negative breast cancer. It's found in younger women. Women who have the BRCA1 mutation may have triple negative. It's associated with that. And it's found in women of color. So African-American women and Hispanic women are more likely to have it, but Caucasian women get triple negative breast cancer as well. Because they can't take that hormone blocker, so they have to do chemotherapy if their tumor is greater than 5 millimeters. But it gets a bad rep because it is a more aggressive cancer. But usually after the first 3 to 5 years, if they have not had a relapse or recurrence, their chances of having recurrence drops substantially. But triple negative breast cancers are the most aggressive breast cancers that we treat. And so for younger women, I really want them to be aware of their breast, because triple negative breast cancers affect younger women, and especially African-American younger women. So what causes breast cancer? Honestly, we don't know. If you knew, you'd be rich and I'd be rich too. We have no idea. We know that the 2 most common reasons people get breast cancer is because they're getting older and they're female. There are other factors that can't be prevented, such as your race, whether you've had breast cancer before, when you start your menstrual cycle, if you've been pregnant. There's some things that we can't change, but there are some lifestyle risks that we can alter, like making sure you eat right, making sure you're not smoking, exercising, decreasing your alcohol intake. I'm not promoting having children, but if you don't have kids, if you have kids later in life, it does increase your risk for having breast cancer. But I put this on here because we really don't know. People have hypothesized multiple things, but every person is different, and we don't know which ones have different risk factors. I may be obese, but I may never have cancer, and you may be very skinny and fit, and you may get breast cancer. So it's very important to be aware of your breast, and it's very important to get your mammograms if you're of the age. So things you can do to reduce your risk, like I told you, maintain a healthy weight, don't smoke, exercise, limit your alcohol. I'm not going to say no alcohol use. I don't want you saying Dr. Robertson is a bummer. But what we tell patients is limit your alcohol use. Oncologists only want patients drinking 1 alcoholic drink a week. We surgeons are a little bit more liberal. We say you can have 3, but don't you go around quoting me. So there has been a bit of a controversy about doing breast exams. And when I say self-breast exams, we typically tell patients to do a breast exam in a certain way every month, 5 days after their cycle. And then it got all kind of crazy where people said, stop doing breast exams. So the self-breast exams is actually not recommended as a screening tool, and it shouldn't be. It should be an adjunct tool. It won't take the place of a mammogram. It won't take the place of seeing a physician for an exam. But the problem was women need to get familiarized with their breasts. So they told people to just stop, so people stopped touching their breast. What they did was a big trial, and the trial said there was no difference in breast cancer survival rates, and women who did breast exams got all anxious. They came in, they got more imaging. They may have had to have some biopsies, and we just scared them to death. So what I say, how I talk to my patients, you need to practice breast self-awareness. You need to know what's normal for you. And this is for you ladies out there as well. Even if you're in your 20s, you can still know what's normal for your breast. You want to know how it feels. You want to know what's normal for you. I always tell patients that looking at your breast is free. You don't have to wait in the exam room for me. No copay. And it's much quicker than waiting to see me. So some of the things that you want to look out for is you want to see if there are any lumps in the breast. Is there any skin dimpling? Maybe the tumor is pulling things in. We call it peau d'orange, or an orange peel appearance. That's not normal. If you have a rash around the nipple, that may be a particular type of breast cancer called Paget's disease. If the nipple's being retracted inward, that could be a lump behind the nipple pulling it in. That's abnormal. If you start leaking blood from your nipple, that's not normal. If your breast is misshapen. Now, I want to say that no woman has the same shaped breast. I call them fraternal twins, not identical twins. So no breast is the same. But if you notice that one breast has gotten really, 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 really small, shrunken up, like maybe there's a large tumor in there, pulling it inward, that's abnormal. But asymmetrical breasts are usually not abnormal. And people with persistent pain, you need to investigate. Pain is rarely a sign of breast cancer. However, the example I gave earlier, there was a woman that came in with pain, but we investigated and we found something totally different. So if somebody comes in with persistent pain, you need to investigate because it is a breast complaint. But most people that come in have no symptoms of breast cancer. And so that's why it's very important for women to get their mammograms. Remember the picture I showed you where the mammogram can pick up something as small as a rice grain versus when she can feel her breast and it's the size of a lemon. And we want to get early detection if we can. So I want to say thank you, and I'm available for questions. And I will look, web shadowers, where are the questions? Let's see.
We sent them in the Zoom chat. So when you pop open the chat, only you'll be able to see it. The viewers won't be able to see it.
So would it be possible to remove the breast and keep the nipple? So yes, in certain patients, what we do, how we make that decision is their cancer has to be a certain size. It can't be within 1 centimeter of the nipple. They can't have huge breasts because the blood supply to the breast won't survive if we do the mastectomy that way. So like the last patient I just showed you, we were able to save her nipple and her skin. So yes, it can be done in certain patients, the right patient. Not every patient can have that done. Advantages and disadvantages of having your own practice. I'll say the biggest thing for that is overhead. You have to pay for everything if you own your own practice. You're paying your own employees, you're paying for your rent, you're paying for every supply that you buy. So it can be very expensive. But an advantage is you are the boss. So I enjoyed it for 9 years. No, unfortunately, the question was for a mastectomy, is it possible for them to get any tissue back? No. So when we do a mastectomy, we can't remove 100% of the breast tissue because we're not God. We don't know where every ounce of breast tissue is. But we remove about 100. Well, we remove 99% of the breast tissue, but it's not possible for it to grow back. It says, a question says, how do patients make up for the loss of immune cells? There's so many lymph nodes across your body. Those few lymph nodes don't make a difference for immunity. However, removing the lymph nodes when we do a mastectomy, you have to be very careful in the axilla or under the arm because those lymph nodes also drain the arm. So if you are just cavalier going in there, not paying attention and being very thoughtful for how to operate, and it can still be done no matter what, removing too many lymph nodes or removing a lot of lymph nodes can cause lymphedema, which is a risk of doing the procedure. So those women can get very enlarged arms. That fluid can't be drained out of the arm. So that is a side effect of doing axillary surgery. This asks, what is your typical day as a breast surgeon? It depends. You can be as busy as you want to be for a breast surgeon or very lazy. So for me, my days were very, very busy in my private practice. For example, on a Tuesday was our big clinic. I would end up starting clinic at 8 o'clock. I wouldn't leave clinic till 6 o'clock. And I actually would still be doing my notes at 8 o'clock because that was the day I would see patients, I would review mammograms, I would examine breast, I would go and do biopsies. Some days I had surgery scheduled in between. So it just depends. You have to make it how you want it. I like being very busy. But the weekends are nice because it's not like taking trauma calls. So other than just taking a phone call, I'm not usually required to come back into the hospital unless one of my particular patients is having issues. Somebody asked about neurofibromatosis. There is actually a link, and I cannot remember the genetic mutation. It might be it might be P53. But I would have to look that up. Somebody asked about neurofibromatosis, and there is a risk with breast cancer. It's not a high risk, but I would have to look up that specific mutation. So if you want to email me to remind me, I will look that up for you. Let's see. Would you do a lumpectomy for atypical hyperplasia? Well, I guess you could say lumpectomy. We do an excision because we want to make sure that there's no cancer there. But we don't do a cancer operation. What happens is the patient may have a biopsy. They see radiology. Radiology has left, we have a little clip left in there so we know where to go. The radiologist puts a device or a wire so we know what to take out. And we bring them to surgery and remove that area. We're not trying to get what we call margins or clearing them of anything. We just want to make sure that what we take out does not have cancer in it. So yes, we would do a lumpectomy, but it's not a cancer operation. In the radical mastectomy, would you also remove the pectoralis muscle? Not the entire thing, just what is involved with the cancer. But like I told you, radical mastectomies are rarely done anymore. They're very disfiguring, and we have better options because people who come in with advanced cancers like that will typically get we will get chemotherapy first, and it helps shrink it down. But I have done a radical mastectomy, but we don't remove the entire pectoralis. It's just where the cancer is involved. And we don't do that very often. Somebody asked about dieting when you're going through cancer. I am of the belief that diet does control a lot. There's no magic bullet for curing cancer, but I think you can boost your immune system by eating right, by exercising, by eating fresh fruits and veggies, trying to minimize pesticides, not smoking. So when patients are getting chemotherapy or going through treatment, we don't discourage them from, I wouldn't recommend they did make drastic changes. Like I didn't say go become vegetarian or stop eating sugar completely, but it is helpful to be healthy because it helps you deal with chemotherapy a little bit better, but it doesn't keep you from getting breast cancer. Yes, birth control long-term can increase your breast cancer risk. You don't, if you are a person who are in their 40s and you've been on it a long time, yes, it can increase your breast cancer risk. Somebody asked if you don't breastfeed your children, does it become one of the factors of getting it? You can breastfeed your children and still get breast cancer. It's just that when you breastfeed or if you have babies early, kind of the thought behind having babies, let me see a way to explain this simply. When you're an adolescent, you have immature breast cells. And so by having the baby, those cells become more mature because they're exposed to estrogen. So it keeps them from having alterations in the DNA. So the longer you don't have a child, or this is kind of weird, this is scientific, but the longer you don't have a child, you might have some alterations in your DNA that could put you more at risk for breast cancer. If you don't breastfeed your children, that's not a reason to breastfeed. I don't want you thinking that Dr. Robertson said, if you don't breastfeed, you will get breast cancer. There are other things that you can control by maintaining a healthy weight, making sure you get your screening exams. If you have a family history of breast cancer, going in to be checked out earlier, not smoking, not drinking. So yes, it can increase your risk, but I don't want that to be like the topic. I don't want you to think that's the only thing you take away from this, okay? It says, if a breastfeeding mother develops breast cancer, are there complications for the child being breastfed? No, however, if they're getting chemotherapy, they cannot use, we're not gonna have them, they're not gonna be, well, if they have breast cancer in their breast, they're not gonna be doing breastfeeding anyway. And if they're doing chemotherapy, you can't breastfeed, you're not supposed to be breastfeeding with the chemotherapy in the system. Let's see. How do I manage my personal life? I don't know how to answer that. I guess okay. I love what I do. If you're asking if I'm married or have children, no, but that has nothing to do with my job. I think whenever you decide, no matter what you decide to go into, you need to make sure that you're happy with it. You need to make sure you're at a place that you're happy, and you don't want to go into medicine just because that's what you've been telling people. You have to have a passion for going into medicine. So it's your life is what you make it, okay? I don't really know how to answer this question. It says, how does a male know he simply has fat near his chest wall, or whether it's actual gynecomastia? Well, gynecomastia is where you actually have the development of the breast. So it will look like protrusion of the breast tissue. If you're a very muscular person, though, it can make you look like you have gynecomastia. Honestly, if you're worried about it, go see a physician to actually examine you, and they can do an ultrasound and tell the difference between breast tissue and fat, because fat and breast tissue look totally different on the ultrasound. Does soy increase your risk for breast cancer? There's conflicting information on that. If you were in a country, if you were in maybe Asia, because they have been exposed to soy longer than us, they start eating it younger in life, they actually have a protective benefit. However, eating a large amount of soy here, we don't really know, there's conflicting information. For our breast cancer patients, I don't like them eating a lot of soy because soy can have phytoestrogen, which is an estrogen that's in plants. And so if they are changing their diet completely, only eating soy, but we're also giving them hormone blockers because they're being treated for breast cancer, there could be an interaction. But we usually tell patients you can still have soy. just don't take soy extracts, and don't try to limit your soy to maybe 2 servings a day if you're worried about it. But there has been conflicting information on soy increasing breast cancer. What kind of innovation makes my job even more efficient? I didn't talk about this, but one thing that I love is that if you have an early stage breast cancer, and we can do a lumpectomy where we just take the cancer out, certain patients, depending upon the pathology report, if it's a favorable cancer, early stage cancer, instead of that person having to get radiation over a 6-week period every day for 6 weeks, those patients can come in, I can do their lumpectomy, and while they're asleep, we have a radiation machine that we put into the chest wall, and we're able to do radiation while she's on the table, and then we're done with her surgery and her treatment, and she takes a pill. So instead of coming in every day for 6 weeks, the intraoperative radiation machine has changed or revolutionized in some patients having to get radiation every day. So yes, intraoperative radiation machine. And if you look on my page, my Instagram page, I think way down below, I have a picture of it. No, breast, actually, I'm doing another talk and I actually talked about this. It says wires in your bra. No, that's totally false. So how that came about was people thought that if you had underwires, it was compressing the lymphatic flow of the breast, trapping breast tissue, trapping fluid, and the breast cells were able to develop. Well, we all know that breast cancer happens at a cellular level, so that does not occur. There's no backwards flow of fluid. So no, wearing an underwire bra does not put you at risk for breast cancer. So please wear a bra. I don't want to see you sagging when you come into my office. There is, well, so we talked about this, a link between breast cancer and ovarian cancer, yes. Uterine cancer may be a DNA suppressor, but it's not linked with BRCA1 or BRCA2. This asked, so for breast surgeons, so what has happened with COVID in breast surgeons is that we're seeing people come in with a lot of issues because number A, they may not have wanted to get screened, but don't forget that the mammography for screening exams, they put that on hold for several months. So we are seeing patients coming in with a little bit more disease, but breast cancer doesn't stop because there's a pandemic. So when patients have a lump in the breast, or if there's some kind of abnormality, you still need to come in to be seen. So don't let that scare you away. We're having issues with people not coming in for their normal screening exams. Now they do social distancing, they clean the machines very well. So people can now come in to get their annual mammogram. So if anybody's listening that is of the age and hadn't had their mammogram, you can go and get scheduled for your mammogram. I don't have any more questions on here, guys. So, okay, web shadowers. Let's see.
We're sending more questions.
Okay. Well, I can't do this chat. I'm too old for this, guys. You forgot I'm almost 45 years old. This is too much for me. So I'll have to wait on the questions here. Oh, I can't do that. Okay, let's see. And if you have questions you don't want to ask in the chat, I get questions from medical students and pre-meds all the time. Some questions I can answer. I am not a physical therapist, so I get physical therapy questions. I'm not quite sure why, but I can get the information for you if you need it. Right, this is going too fast. Hold on, let's see. No, there is no increased risk for having breast cancer with implants. However, implants can obscure breast cancers. So there's a special implant mammogram we do. So when women come in with augmentation, I'm not talking about we've done a mastectomy on them. If we've done a mastectomy and they have implants, there is no breast tissue to be mammogramming. So we do not mammogram people who've had mastectomies. But if they have augmentation, we do implant displacement. We push the implant out of the way. There's a way that the mammogram tech does it so we can look at the breast tissue, but it doesn't increase your risk for breast cancer. Why do people say not to wear a bra when you sleep? I have no idea. I don't wear a bra. I don't mean to get too personal, but it's uncomfortable. Why would you want to wear a bra? Ugh. But it has no bearing on lymphatics. It has no bearing on breast size. It has no bearing on developing breast cancer. If you want to wear a bra, wear a bra. If you don't, don't. But it has no bearing on anything dealing with any breast cancer. So I have no idea why people tell you don't wear a bra. What made me want to become a breast cancer surgeon? Like what I told you is that I wanted to be an infectious disease doctor initially. I've always known I wanted to be a physician since I was a little bitty kid. And I didn't know what a surgeon was, but I knew I liked blood. So as a little kid, I would cut up my stuffed animals. My parents thought I was either going to be a serial killer or a doctor. So they encouraged me to be a physician because they didn't want me killing people. But I like cutting up my little stuffed animals. So what happened was when I went into medical school, my third year of my medical school, you are introduced into all the fields of medicine. And my last rotation was general surgery. And I really liked that the general surgeons could take care of a patient, never consult the medicine team. They were able to take care of the infections. They were able to do the surgery. They saw that patient in the clinic. I liked the interaction in the operating room. My first OR case as a student was a heart bypass. And I just loved the interaction between the surgeon and all the people in the operating room. And the biggest thing is I like the surgeon being the boss. I thought that was pretty cool. He's telling people what to do and they're doing it. So I like being the boss. In what situations we recommend a complete hysterectomy for a patient with breast cancer? I would not. Typically, I stay in my lane because I'm not a gynecologist. When people have certain genetic mutations like the BRCA genes I was telling you about, it increases their risk for ovarian cancer. And since we don't have a good screening tool for that, if those patients have finished having babies and are ready to remove the ovaries, we would recommend it at that point. But just because you have breast cancer does not mean you need to do a complete hysterectomy. I don't want you taking that away from this discussion at all, okay? Very seldom do I see, well, they're asking about lymph nodes. So no, the lymph nodes, removing lymph nodes doesn't increase the risk of cancer spreading anywhere. And removing the lymph nodes doesn't make the cancer spread to the chest wall either. Very seldom do we see breast cancer invading the muscle. However, in advanced cancers, and I'm telling you, I've seen people with advanced cancers, they get diagnosed with an aggressive triple negative breast cancer and they don't do anything. You know, they know they have a cancer and they let it grow and grow and grow. It will invade, it will just keep growing. We don't know what time period, but I've seen a lady where it has grown into her muscle and into her rib cage and she did not want to have surgery and she ended up passing away from her breast cancer. So it doesn't invade the muscle very often, but if you do nothing to the cancer, it will continue to grow. Oh, child, I can't tell you nothing about an IUD. I don't work down there. I stop at the navel. That's why I'm a surgeon, not gynecologist. Call a gynecologist for IUD. Somebody's asking about birth control. Well, remember, those are exogenous hormones. You're giving yourself hormones. So if estrogen and progesterone can increase the risk of breast cancer if it's circulating in the system and you're giving yourself hormones. In older women, I'm not saying you can't take birth control pills, but if you're high risk or have a genetic mutation, that can add to the increase in breast cancer development. So the muscle that it could invade, so if you go back, if you look at any anatomy book, the breast actually sits on the chest wall. And so the major muscle is the pectoralis muscle. Near the axilla, you have the pectoralis minor. And so the pectoralis muscle, there was a slide I showed with a gentleman having a mastectomy. The pectoralis muscle sits there. So if the breast cancer keeps growing backwards into the wall, chest wall, it can invade the muscle and the bone. No, doesn't matter your breast size. You can have big breast or small breast. It doesn't have any bearing on you developing breast cancer. It does have a bearing on what we can do with the breast. So if you have very small breast and you get breast cancer and it's a large cancer, sometimes there's no way for us to conserve your breasts because if we try to just take out the cancer, you'll be left with a very horrible cosmetic result. Bigger breasted women are not at increased risk or decreased risk for developing breast cancer. But we can do, if they have a huge breast and the breast cancer is not very big, we can conserve their breast. We can take out the cancer, tissue around the cancer, and they can be left with breast without having to have a mastectomy. Some patients. No, so this asks about preserving the nerves. When we do a nipple-sparing mastectomy, it's the way I describe it to the patients, because you have to be very honest. We can make a very good looking breast like I just showed you, where it looks really realistic. However, we are not God, and we cannot make the breast like he made it. So we remove everything. When we do a nipple-sparing mastectomy, I am literally removing the breast tissue all the way up to the very fatty layer of the skin. And so that nipple, all the blood, well, it has blood supply, but the nerves are gone. You're not going to have the same feeling. Women who have mastectomies or reconstruction they're numb. And so it looks like the example I always use is like a stuffed deer. So you have a deer, you kill it, you stuff it. You put it out with the other deer are coming around like, hey, it looks like us, but it don't feel like us and it's not moving. What is this? A breast that's been reconstructed is not the same as a breast that God gave you. So no, preserving the nerves, they're not gonna have feeling. We have to be very honest with them when that happens. No, I would not recommend you removing your ovaries as a precaution for breast cancer unless you have a genetic mutation. Removing your ovaries decreases breast cancer by 50% in women who have the BRCA genes. But no, just removing I would not recommend you removing your ovaries just because you don't want to get breast cancer. That's an operation why would you want an unnecessary operation? No, no, no. Only if you have a genetic mutation. Don't go around removing your ovaries. And don't you say Dr. Robertson told you to remove your ovaries to not get breast cancer. I'm gonna come find you if I hear you say that, okay? What does this say? My hopes for my field in the next 15 years. In surgery or just breast surgery? Honestly, in all surgical specialties, to see more people, to see more females and to see more people of color. Because as you can imagine, once you get to surgical subspecialties, there's very few people that look like me. For African Americans, we only make up 2% of the of physicians. And so you can only imagine, when I became a fellow of the American College of Surgeons, there were 3,000 initiatives that year where we got the big hood. But of African American women, there were probably 3 of us out of 3,000. There was not a lot of us. Yes, we have had people have a mastectomy where they had breast cancer again. Because we can never remove 100% of the breast tissue, if any cell or sometimes it has nothing to do with the surgery, but I have had patients, not too common, that have had breast cancer happen again, and then they're reconstructed breasts. One of the things we tell patients is that if you remove this breast, your chances of having breast cancer again are pretty slim to none. However, it's never 0%. So when patients want to remove both breasts because they never want to deal with breast cancer again, so like the lady that I was just telling that we did the case on, the reason why we removed the opposite breast, even though it was normal, is because she had a genetic mutation that put her at increased risk for developing breast cancer. But if she did not have the genetic mutation, I would not recommend she remove the other breast unless that's a personal choice. But I have to tell them it doesn't keep you from getting breast cancer if you remove both breasts. You can still get breast cancer in the skin. Breast cancer can come back on the chest wall. It's not very common, but it can happen. So removing your breast does not keep you, doesn't give you a 0% chance of never having breast cancer again. I think I answered that question about removing the ovaries for breast cancer, because I told you it was a 50% chance, a decreased risk for patients with certain genetic mutations. Not every genetic mutation requires you to, so genetic mutations can overlap. There are some genetic mutations that cause breast cancer, but not to a greater degree, like the BRCA genes. Some of them cause pancreatic cancer. Some of them cause colon cancer. An example would be, there's a gentleman that I did a surgery on who actually, like I told you, every male needs to get genetically tested. His only family history was that his brother had colon cancer. So we genetically tested him. And ironically, he did have a genetic mutation, but it had nothing to do with breast cancer. He had no increased risk for breast cancer. It increased his risk for having colon cancer. So all genetic mutations can overlap, and some don't increase risk breast cancer at all. Like I told you, I have a genetic mutation. I don't know if you know this. If you go to my Instagram page, you'll see that I am a kidney cancer survivor. And I had kidney cancer because I have a genetic mutation that puts me at risk for kidney cancer. It has nothing to do with breast cancer. Racism or sexism as an African-American woman in the medical industry? I mean, I did residency actually, I will have to say, I did my residency at the University of Arkansas, and I don't ever feel that my race played an issue with patients at all. It's all how your attendees introduce you, and if they show confidence in you, I don't remember if it happened without me knowing, because I usually ran the team, and I don't remember anybody ever saying, I don't want her treating me. However, I have seen microaggressions where they will turn to look at the medical student, the white male medical student, when we're coming in to talk about a big pancreatic operation, and I simply say, he can do your operation, but he's been a medical student for 1 week. I've been doing this for 5 years as a resident. I felt protected at my residency, but I think instead of racism, I think there's more sexism, and it's just a bias with a female being a surgeon. But yeah, I mean, you're going to find racism anywhere you go in medicine. You just have to learn. I mean, I'm a breast surgeon. I'm a surgeon in a white male dominated field. You got to learn to be tough. Don't show fear. Know your stuff. Make sure your exams, your scores are excellent so that they can't question you about anything. And I've got the favor of God behind me, so I don't worry about anything. You see where I am. Whatever's meant for you is meant for you. So I'm fulfilling my purpose in life. So I don't let racism or sexism bother me, because I know how to handle that real quick. For advice for women of color, don't let anybody, this is for anybody, but not just women of color, but for any female, do not let anybody tell you what you can't do. I remember being a medical student, and I specifically went to a certain surgeon, a female surgeon, and told her I wanted to go into surgery. She looked me up and down and said, I don't see you as a surgeon. You don't have what it takes. I was devastated by that. And I went over to a different surgeon who worked at the VA, and he took me under his wing, became my advisor, and is the reason really why I applied to the University of Arkansas, because he put that on my list. Don't let anybody tell you what you can't do. You make sure you do well on your boards. You make sure that you know your stuff. You're well prepared when you round. When you are in college, make sure you do well on the MCAT, but don't let anybody tell you what you can't do. And if you want to be a surgeon, go ahead and be a surgeon. Don't let people discourage you. Oh, it's a hard road. Yes, it's a hard road, but most things that are hard are worth fighting for. So don't let anybody discourage you. For any of you, male, female, white, black, don't let people tell you what you can't do. So the person that had the mastectomy had reconstruction. And so her cancer actually came back in the reconstructed breast. So we had to take that whole breast down, and we had to do reconstruction a different way. So I think she may have had reconstruction from her back. I think we took tissue from her back, the latissimus muscle, to make her breast. The plastic surgeon did. We had to take that entire reconstructed breast down about 2 years later, and we had to take tissue from her stomach to make a new breast. And actually, unfortunately, that person has an aggressive cancer where right now she's dealing with breast cancer yet again in her lungs. So she's been dealing with breast cancer for a couple of years now. And that's the last question I have. Is there any more questions? Oh, Kimmy fan, don't be burnt out. I don't know if you saw my, presentation at the very beginning. When being a high school student, I made very good grades. I had a GPA of our GPA was on a 5.0 scale. My GPA was way up there. Had a full academic ride to college. I don't remember what I made on the ACT, honestly. I'm so old now. But I did well in school, and my parents encouraged me to go into medicine. So because I wasn't the special child, I'll just say I was a very hard worker and very smart. But doing that all throughout college burned me out, Kimmy fan. And so I didn't tell my parents I didn't apply to medical school. I just kept it a secret. So my night before I graduated college, my little brother, who was actually a freshman at the same school, he sat down and said, it's time to tell mom and daddy you didn't apply to medical school. That conversation did not go well at all. Did not go well. My parents thought I had lost my mind. But I knew I wasn't going to do well in medical school because I was tired. I wasn't ready to take an MCAT. I didn't feel mature enough to go to medical school. I'm not saying that's not for everybody. I just wanted to live my life and be normal for a while, like a normal person. So I worked. I did volunteer work. I did things I worked at the blood bank. I worked as a pharmacy tech. I enjoyed what I did. And when I took anatomy and physiology. I got a little book for dummies, how to make cocktails, because I never drank when I was in college. I was a Dudley Do-Right. So I had fun. And after a year and a half, I was ready to go. And I applied to medical school and I got in. I applied to one medical school because that's the one medical school I wanted to go to. And I got into that one medical school because that's where I wanted to go. So don't get burned out. Don't let anybody pressure you to go into school until you're ready. Because the worst thing is to get into medical school and then you flunk out because it's not what you thought. I had colleagues that didn't, after the first year they left because it wasn't what they thought it would be. So Kimmy fan, my heart goes out to you. Don't be burned out.
Thank you so much, Dr.
Y'all are so sweet. They're talking about I'm inspiring them. Well, thank you very much.
Thank you so much for
You're welcome.
Such an informational presentation and for answering all of our questions too.
You're welcome. Ladies and gentlemen, if you ever need me for anything, follow me on social media and you can email me at any time for questions or if you just want advice. And I wish you very well in the future for yourselves.
You're such an inspiration to so many of us. Thank you.
Oh, have a great night, guys. Watch the presidential town hall, okay?
Everyone make sure to check out her socials. Her Instagram is Dr. Yara Robertson.
Additionally, thank you all so much for attending. The link to the Google form has now been posted in the comments and it's also in our Instagram bio. So please fill it out within the next 30 minutes for us to receive verification of your attendance. Again, thank you so much, Dr. Robertson. I found myself laughing so many times in this presentation. And
medicine should be fun, not.
Thank you.
Okay. Guys, have a great evening. I'm leaving now.
You too. Take care.
Bye-bye.